Hello, everyone, and welcome. At this time, if you would like to, you can camera on. While the speakers are speaking, we'll ask that you camera off. And I can introduce us. So welcome to the American Spinal Injury Association Early Career Webinar Series, Season 1, Episode 6 on Sexual and Reproductive Function After Spinal Cord Injury. This is Friday, the 26th of August, 2022 at 3 p.m. Eastern. Awesome. Or no, I'll mute this person, sorry. And Asia's Early Career webinar series is a bench to bedside view of the landscape of spinal cord injury research and medicine through the eyes of us, early career professionals. So this is a multi-part series featuring episodes focusing on a single topic relevant to SCI medicine and research. In each episode, a dyad of presenters will present us a parallax perspective on their SCI topic of expertise. Ideally, one perspective being more lab-focused and one more clinically focused. Each presentation will be 20 minutes with a following 10-minute Q&A. And beyond sharing the emerging work of young professionals in the SCI space, we have two further missions. One, to identify and archive rising stars in the space, and two, to create a community for networking together these people based on a common mission. So you are here for that latter mission. So please participate. My name is David McMillan. I'm an assistant professor at the University of Miami Miller School of Medicine and director of education and outreach at the Miami Project to Cure Paralysis. I'm one of the co-founders, co-producers, and co-hosts of this show, along with Anne E. Palermo, who is not with us, and Raul Sajdeva, who will introduce the speakers. And so please, cameras off and muted while the speakers are presenting. Afterwards, if you would like to ask a question, you can camera on, unmute yourself and ask your question, or drop your question in the Q&A, and we will read that for you. If you do put your question in the Q&A and intend to read it yourself, please let us know that so that we don't fumble over reading it and then you camera on and try and do it yourself. So thanks so much, everyone who's here. This is a great turnout so far, I can see from all the tiny boxes on my screen, and we'll hand things over to Raul.
Thank you, Dave. It's a great pleasure to be here again today for the 6th episode. And this is probably the most exciting one. We all love to talk about sex. So I think judging by the number of participants we have today, it looks like it's going to be an exciting one. Before we start, may I ask everybody to mute their mics, please? We are still seeing some disturbance. Please take a moment to check your mics. They should be muted. Thank you. So today we have two really exciting speakers, Dr. Maryam Berri and Dr. Claire Shackleton, and we'll go in that order. So Dr. Maryam Berri will present first. So Dr. Berri is an assistant clinical professor from the University of Michigan. She's boarded in SCI and brain injury medicine. She is pursuing research in lactational outcomes and management for those with neurological diseases. And she's interested in product development for improving their lactational experience. And her title for the talk today is Considerations for Lactation in SCI, Improving Collection and Delivery. So Dr. Berri, if you would like to share your screen, and stage is yours. Thank you.
Perfect. Thank you so much, Raul. Okay, everything look good on your end, Mike? Okay.
Slide looks good.
Yes.
Thank you. Okay. Well, it's an absolute pleasure to be here with you all. Thank you for joining. So today we're going to be looking at lactational dysfunction in spinal cord injury, but through the lens of consideration for improving collection and delivery of human breast milk. This is a topic I became interested in and more aware of after my firstborn. For disclosures today, I am the sole inventor of the product that we're going to be introducing. Okay, let's just pause for a moment and discuss the components of lactation that may be altered or different after spinal cord injury. In order to do so, we should quickly review normal mechanisms related to lactation. So when an infant suckles, there is a triggering of sensory nerve impulses and a few routes of action to be mindful of. The brain receives the sensory impulses from the areola and releases oxytocin from hypothalamus pituitary, posterior pituitary. The removal of milk and stimulation of the nipple also triggers prolactin release from the anterior pituitary gland. Oxytocin also tells the lactocytes in the mammary gland, hey, it's time to produce milk, in response to the sensory nerve impulses. Oxytocin triggers the myoepithelial cells to squeeze milk from the alveoli into the lactiferous ducts. So they pool here and milk is discharged through the nipple pore. This is a positive feedback loop. And of course, prolactin concentration increases rapidly with suckling to keep this sustained. Another component I want you to be aware of is the autonomic nervous system. So the mammary glands are actually modified sweat glands. And so they receive efferent autonomic innervations that are entirely sympathetic in origin. So that would be the sympathetic preganglionic neurons that actually come from about T1 to T5. Of note, the autonomic standards don't mention lactation yet. There is also the supraclavicular nerves that do offer some form of primary sensation on the top part of the breast. So because of what we just discussed, one can expect that there's going to be some problems with lactation in the setting of a spinal cord injury. The literature describes impaired letdown reflex in women with neurologic level of injury of T4. Could be reduced if it's in between T4 and T6. Also, the literature says that T6 NLI and higher has insufficient milk production. So that's the concept of low milk volume. Ejection also is an issue with, of course, increased risk of autonomic dysreflexia. Depending on motor level, poor latching, difficulty holding the infant, upper limb function is needed for positioning and awareness of where that latch is. If you're using a breast pump, that is also important. It's difficult for a patient to maneuver flanges and pumping material. Because of this, there's an increased risk of clogged ducts, which can lead to mastitis due to the poor hand function and complete breast emptying. For example, after a breast pumping session, a patient may use hand expression to get the last of the milk out, and that is something that they can't do, and that's important for decreasing risk of mastitis and clogged ducts. The breastfeeding duration is actually shorter in this group as well when compared to levels with T6 and below. And breastfeeding, of course, is supplemented with breast pumps, and some mothers supplement with formula. So to review the puzzle pieces, there's the neuroendocrine reflex that we're dealing with, and the hormones, sensory innervation, autonomic control, and physical limitations, latching. So we have a clinical problem. Given the limitations in our existing literature, we pursued an explorative descriptive approach to gathering data about impressions and problems with lactation and spinal cord injury. So we screened consults, inpatient rehab admissions, and outpatient multidisciplinary clinics from about January 2019. This is still ongoing. And we included new mothers with spinal cord injury and or myelomeningocele. Ages were about 18 to 44, and inclusion criteria for this survey was that you've had given birth in the child in the past years, and that you actually engaged in some form of breastfeeding at least one time, and you were able to engage in a telephone or a video interview. If you make note of when we started this data gathering, we ran into pandemic, so things kind of elapsed for a certain period of time. So the items of the survey that are important to what I am discussing today, the clinical scenario, is some of these questions here. I apologize. I should tell you what levels were included in the survey. So we actually had 3 cervical level cords, one C2 Asia A that was ventilatory dependent. This patient actually also had an intrathecal baclofen pump, a C6 Asia C and a C7 Asia D. There was also a patient who had myelomeningocele T12 level, but with status post-AVM rupture. Okay, back to the survey results. So interestingly, mothers actually thought about the decision to breastfeed before baby was born. All 4 of them attempted to breast pump for baby. They were using a breast pump up to about 4 weeks postpartum or more. Caretakers were needed for all 4 to manipulate breast pump, placement, cleaning, etc. Some of the descriptions included a source of anxiety for breast milk volumes when they were first trying to feed baby. And I'm going to show you the data and figures of their breast milk volumes over the course of the first 4 weeks postpartum, and then just some comments that inspired this product development. Some of the items mentioned was, we're dealing with really low milk volumes, especially pumped colostrum and transitional human breast milk. So a lot of the time, this liquid was stuck around the nipple or ring of a bottle rim when they were breast pumping. They were also dealing with having to transfer really low milk volumes to something that needs to be stored, like a milk bag, another container, and there was some concern about losing precious volume through the transfer process. They, of course, complained about the burden of washing and drying breast pumps following feedings, and that there was just too many to keep clean and dry and germ-free. So the breast milk volumes, looking at these first 4 weeks, as you can imagine, are very low. These are averages and estimates that the mothers were able to give us. And essentially, as you can tell here, like the highest volumes came from the patient with myelomeningocele, the T12 level. So in the setting of all this knowledge that we got from the survey, we really wanted to focus on something that can make life a little bit easier for these patients who are dealing with low milk volume. And we really wanted to focus on existing breast pumping technology, because luckily, the Affordable Care Act actually set a standard that insurers must cover the cost of an electronic breast pump or manual pump or rental. So all of a sudden, 1 year into the ACA, everyone who was lactating was able to get a breast pump. So we wanted to focus on the fact that this DME was accessible and available, and we wanted to work within that, within those confines. So it's suboptimal collection and feeding with intrinsic loss of precious volume that could possibly have high risk of contamination through these transfer mechanisms. That was our problem, and this is what we were trying to fix. So if you review the components of a standard breast pump, there is a flange that connects to the connector, that connects to a backflow protector that connects to the tubing of the electrical pump. This ensures that there isn't breast milk going through the tubing, because that would be a bad thing. There is a valve that connects on the inside of the connector and a milk bottle. So we focused on the connector and what we could do to meet the goals at this level. And this is the direct collect. This is currently patent pending, and it comes in many different sizes with threading at the top in a syringe mechanism. It lays flat on a surface so that after collection, it can sit up just like a bottle. All it does is replace the milk bottle, and it connects to the threading that already exists on these connectors. This threading is ubiquitous and universal to a lot of products out there. You can cap and store, attach a standard flow nipple. Patient can pump or manually hand express. If they happen to have a wide neck, the threading extends so that it attaches to a wide neck pump material. This is an example of a breast pump with Amida. This is another Medela example. This type of threading is compatible with soft cup in babies who have suckling difficulties. The threading is ubiquitous to supplemental nursing systems. So you're essentially just adding a syringe to all of this so you're not losing any precious milk volume. Also, the soft feeder eliminates nipple confusion. So in patients that are utilizing this, it is the same item and threading that continues to connect exactly the same way. In babies with cleft lip and craniofacial abnormalities, the special needs feeder is another example from Medela that has the same threading that would be compatible with this device. So we tested this in multiple existing breast pumps. So I actually have far too many breast pumps because of this. The Lactina, Medela Symphony, Medela Freestyle, Medela Pump and Style, Amida Elite, Amida, Maya Purely Yours, Baby Buddha, Even Flow Advance, Lancina Signature, Dr. Brown's Custom Flow, and of course, like I mentioned, the wide necks. So the prototype screening, I want to make sure that you can see this. So of course, a lot of this was done during pandemic. So it was shown to lactation consultants over video. And can you guys see this okay? You've got the flange here. Tubing connection goes here. The threading opens and closes. The valve mechanism is not altered. It sits, it collects breast milk, and it's compatible with things that are available on the market and currently being used. So the certified lactation consultants were really excited about this because it was extremely versatile, that they can just add to their units and offer to patients who have low milk volumes and are struggling. Usually when a lactation consultant is working with a family who has poor latch, they may squirt colostrum. They might squirt sugar water to tell the baby, hey, come a little closer this way, latch this way, etc. Helps with rooting. And with this device, they actually can use colostrum instead or milk instead while they're trying to latch this and not have to use sugar water. Of course, like I said, it eliminates the need to transfer milk to another container, which is decreasing the burden of washing another container, and helps decrease feeding time because it's the same collection device that's being used to feed. So the next steps in our research is that this is patent pending and hopefully should clear really soon. We're working with the university's medical bioengineering team to make sure that the materials we're utilizing are obviously safe for infants and are up to standards with industry. And then we want to have an actual prototype that is sterile that we can use on the floors. We're thinking about testing this product in patients with SCI only, but also thinking about testing it as a comparison group with non-SCI and SCI. We're also working on some attachments that can help accommodate enteral feeds because a lot of babies may be born premature, and can work on devices that help with gravity feeds. And that is the end of this presentation in terms of where we are. And here are references. So I'm gonna go back to this slide for a moment and ask if there's any questions.
Thank you, Maryam. That was a really nice presentation.
Of course, my pleasure.
Anybody has any questions for Maryam?
I do, Maryam. Can you tell us a little about your background and what inspired this project? I guess as a starting point, do you have any engineering training?
No, actually I don't. So the story is that I actually suffered from low milk volume due to a complication during delivery. And I was struggling with this myself. And one of the things that the lactation consultant would tell many patients was to utilize a syringe from the collection device to draw up the volume. And I was always so frustrated, like, couldn't we have thought of something better? Like, this isn't helping, this isn't working. And I just literally thought about this 3 days postpartum, and it came to me. Never had any, time to get to it until several months after baby was born. When I was on a consult in the woman's hospital for one of these patients, it dawned on me, like, this is definitely an issue, especially for patients that I help take care of, patients with brain injury and spinal cord injury. And that was kind of the light to really go forth with this research. We just have a very robust medical engineering, bioengineering program, and they're always asking for clinical faculty for ideas and project support. And I just thought it was perfect timing.
So there was a serendipitous lived experience from you that overlapped with a need in an existing population where you happen to be a board certified physician. It's fantastic. And then your biomedical engineering team empowered you. That's great.
The hard part, they're going to figure out, what materials are going to be up to standard. So that's exactly what they're currently working on for an actual prototype.
Wonderful. We have a question from Lindsay Stevens. Lindsay, would you like to unmute yourself and ask it, or we can ask it for you?
I can also read it, Lindsay.
Yeah, go for it.
I'm wondering where or how we can follow up on this project, on this product as it is patented and tested further. That's a very good question. I'm just waiting to get to that point. The patent literally went through, and I kid you not, 3 weeks before pandemic hit. So movement just started on it early this year, finally, from the patent office. So as soon as that comes through, then I can freely develop this with hopefully grant money and sponsors from some of the larger breastfeeding and breastfeeding companies, which I've been working on, and I have, and it's ready to go. So I don't know. I wouldn't know like where I would say that this is ready to go. But good question. I'll give it more thought.
Are there any preliminary thoughts about a name for the product?
Yeah, so I just call it the direct collect because it directly collects and then you just go into feeding. But that's what I've been going with.
Oh, that's great. It's clever. It's all just to minimize transfer loss, right?
Yeah. Transfer loss. And like what's so funny about all of this is that it fits with almost everything that we have out there already. So like let's get it out there so that families can use this, especially in those that have intrinsically low breast milk volume, because it really is a source of anxiety to even lose some drops of something that could be baby's first vaccine, for example, from the colostrum. So just, something to help bridge that gap.
Excellent. If there are no other questions from the audience, I would like to switch the speakers here. We move on to the second talk of this session by Dr. Claire Shackleton. Maryam, you can stop sharing your screen. Thank you. So it's a great pleasure for me to invite and introduce Dr. Claire Shackleton, who has a clinical background in neurorehabilitation from South Africa. And she's now a postdoctoral fellow in Dr. Krasikov's lab at ICORD in Vancouver, Canada. And her research relates to autonomic dysfunctions following spinal cord injury, with a particular focus on spinal cord stimulation. And today she's going to talk about spinal cord stimulation for improving sexual dysfunction after spinal cord injury. The title of her talk is The Birds and the Bees, Female Sexual Dysfunction Following Spinal Cord Injury. Take it away, Claire.
Thank you, Rahu. I'm just going to share my screen. 1 second. Sorry, Rahul, can you see that now?
Yeah, we
this
see
is
a title slide.
Okay, great. Sorry for the delay. Thanks for the introduction. I'm Claire. As Rahul mentioned, I'm a postdoctoral fellow with Dr. Krasikov in Vancouver at ICORD. And today we're going to be focusing on female sexual dysfunction after spinal cord injury. I have some disclosures, both from Dr. Krasikov's lab, as well as Dr. David Darrow in Minnesota. And today we're going to focus on the neuroanatomy and physiology of female sexual function, as well as look at what happens to sexual function after a spinal cord injury. And I want to look at what evidence there is for spinal cord stimulation on improving sexual function, with a specific focus on the eSTAND clinical trial. So female sexual function, or sexual function in general, is a combination between autonomic and somatic neural pathways. So the parasympathetic activity in the lower sacral spinal cord is responsible for pelvic vasocongestion and smooth muscle relaxation. And this triggers the engorgement of the labia and the clitoris, as well as vaginal lubrication during arousal. The sympathetic activity in the T10 to L2 area, as well as somatic activity in the S2, S4 area, is responsible for involuntary rhythmic contractions of the pelvic floor. And this is for orgasm. And what's important to note about arousal is that it can be either psychogenic, which I like to think of as brain arousal, where you are aroused by sexual thoughts or by sexual fantasy, whereas you could also get arousal as reflexogenic, which is direct tactile genital stimulation. And the ability to experience either psychogenic or reflexogenic arousal is dependent on the severity and the level of a spinal cord injury. So what happens after a spinal cord injury? So here is a curve adapted from Masters and Johnson in 1966, who proposed a 4-phase sexual response cycle: excitement, the plateau, the orgasm, and the resolution. And here we propose a depressed cycle after SCI. So in the excitement phase, there is firstly decreased sexual desire, as well as decreased genital sensation and decreased vasocongestion and vaginal lubrication. Then there's the plateau phase, and then people with SCI will struggle with orgasm, so a decreased orgasmic capacity, as well as a latency to orgasm. They might also experience pain during sexual activity. And lastly, in this resolution phase, people with spinal cord injury will have decreased sexual satisfaction. And all of these dysfunctions can result in increased sexual distress. And here I want to highlight that in order for any sexual complications to be considered a dysfunction, it has to cause sexual distress. Without the distress, they're just complications. So sexual dysfunction is very common after spinal cord injury, and it has multiple influencing factors. So it could be psychological, low self-esteem, poor body image, depression, increased anxiety, social and emotional. A big contributing factor here is relationship status, so the quality of your relationship, as well as intimacy with a long-term partner. And lastly, the physiological component, which is really important after a spinal cord injury, because there's multiple secondary complications or secondary consequences of spinal cord injury. So pain, spasticity, pressure sores, they might all impact mobility and positioning during sexual activity. You have autonomic dysreflexia, which is a major health concern during, specifically for males during ejaculation, but also during orgasm for both females and males. And most importantly, bladder and bowel incontinence is a major contributing factor to sexual satisfaction and willingness to engage in sexual activity. So all of these different contributing factors will reduce sexual function, decrease desire, and impact sexual satisfaction. So why is sexual function important? So Anderson showed that after spinal cord injury, especially for people with paraplegia, sexual function is rated as the most important recovery target. And for those with quadriplegia, it was the second most important priority. But why are we so interested in females specifically? At the moment, treatment options are inadequate, and they're also driven towards fertility and reproduction. And that means most of the focus has been directed towards males whose fertility is affected after spinal cord injury. Because females are still able to reproduce after a spinal cord injury, there's less research on them and less priority given to their sexual needs. What's interesting, though, is that Anderson showed when people were asked their primary reason for pursuing sexual needs, fertility was actually one of the least commonly reported reasons, and most of it was directed towards intimacy or sexual needs. So what is the evidence for effective treatments for sexual function? So as I said, there's very few treatments directed towards female function. And as we all know, spinal cord stimulation is becoming a really hot topic for spinal cord recovery, both for motor and autonomic functions. And here we have two case reports, one by Susie Harkimer and her team in Louisville. And they showed that a single male improved his erections as well as his orgasmic capacity. Another case report by Dr. Darrow and his team in Minnesota also showed improved orgasmic capacity in a single female. However, both of these case reports were purely anecdotal evidence. So here we want to look now at the E-stand trial. And this is by Dr. Darrow and his team in Louisville. And they wanted to assess the effect of epidural spinal cord stimulation on restoring motor activity as well as autonomic functions, which included pelvic organ function. And the results of these two areas have been published previously. But we wanted to know, okay, what was the epidural spinal cord stimulation doing for sexual function? So it was a case series. We looked at 3 females, thoracic injuries, motor complete, and they were implanted with a neurostimulator at T11, T12, and they received 13 months of daily stimulation. And most of them used the programs almost 24 hours a day. And every month we would look at female sexual distress as well as female sexual function. And these were 2 questionnaires. And here we have the results. So very importantly here, we can see a 55% reduction in distress. And this is really critical from what I mentioned previously, that for other dysfunctions to be counted as dysfunctions, they have to cause distress. So if we reduce distress by almost half, it means that those sexual dysfunctions are not as severe. In the sexual function index, we saw that there was a 13% increase in overall function with specific improvements in arousal, orgasm, desire, and satisfaction. There were no changes in pain or lubrication. Pain was not present at baseline, which is why it might not have changed. So in other words, stimulation did not cause pain. And lubrication may be due to the fact that 2 of the women were postmenopausal. And we know that you need estrogized cells in the pelvic area in order to produce vaginal lubrication. And so to give a nice summary of what those results show, in red, we can see pre-stimulation. Okay, again, very high distress levels and low function. Post-stimulation, there's a significant decrease in distress and really nice increase in the other domains of sexual function. So what are the key take-home points? Firstly, really want to push the message that sexual function is a key priority for people with SCI. At the moment, it's under-researched, it's under-prioritized, and we should be addressing this because it's a patient-centered outcome. Secondly, at the moment, based on preliminary evidence, spinal cord stimulation, specifically epidural, looks like it's a promising treatment for improving sexual function and reducing sexual distress. Future studies are coming out where we will be comparing or trying to see if you can get similar results with transcutaneous stimulation. And my last point is that due to the complexity of sexuality and all the multiple factors influencing it, it will likely require a holistic approach and a multidisciplinary team in order to address sexual dysfunction. And we recommend including cognitive training in mindfulness, which has been shown to significantly reduce sexual distress post-SCI. And that is the end of my slide. Sorry, it was a very quick presentation. So if anyone has any questions, please feel free to ask.
Wonderful talk, Claire. Thank you so much. We are doing really well on time. So we have definitely time for as many questions as audience has. I think we already have one question from Amy. Amy, would you like to unmute yourself and ask the question? Okay, I will ask on behalf of Amy. How are you distinguishing between sexual distress versus sexual complication?
Okay, so the sexual complications component would be from the questionnaire addressing sexual function. So those are the questionnaires that address the different domains, so orgasm, lubrication, desire, those, whereas sexual distress is a separate questionnaire purely on distress. And in order to have those complications from the one questionnaire to count them as a clinical diagnosis of sexual dysfunction, there has to be sexual distress present. So they are separate questionnaires, which is how we measured them. But for the diagnosis, you need to have distress.
Mm-hmm. Great, great. Then we have a couple of questions from Melina. Melina, would you like to ask them yourself?
No, it's okay. You can read them for me.
Sure, sure. Okay, so the first question from Melina is, did the patient receive information regarding sexuality during different sessions?
No, so that's also a very important point to highlight in the study, was that sexual function was actually a secondary outcome. So motor and cardiovascular were the primary outcomes of the ESTAN trial. And participants were doing home-based stimulation and only completed sexual questionnaires once a month. So no, they did not receive any sexual counseling.
I see, I see. So let me connect that last question with that questionnaire, since you mentioned, what questionnaires were you using? This is a question from Caitlin Brosnan.
Okay, it's called the Female Sexual Function Index and the Female Sexual Distress Scale. And they have both been validated and are both shown to be reliable in a STI population.
Great. I'll go back to Melina's question number 2. How can you tell if the sexual distress was because of the treatment or other psychological issues, such as getting more information about sexuality?
Mm-hmm. So as I said, we didn't really share any more information. We didn't have education sessions with the participants on sexuality and sexual needs. So we know it is unlikely to be from that, but it is a very complicated topic, sexuality in general, both for able-bodied people as well as people with spinal cord injuries. So we are proposing that stimulation intervention had a positive impact, but at the same time, it could have been more awareness of their sexual needs, because they're now focusing on the outcomes and they have to think about the questions. So they might have been more in tune with partners. They might have been happier that they're addressing certain needs. They might have been in a better state of mind. So there's multiple factors. Additionally, I mentioned that things like incontinence can be a major contributor. And in this ESTAN trial, they also showed that there was an improvement in lower urinary tract incontinence, and therefore they might have had an improvement in one area that runs on and impacts sexual function as well. So It's very difficult to pinpoint one thing.
Claire, you shared some data about changes in their orgasm. So did the patients feel orgasm in the genitalia?
Mm-hmm. Yeah, that's a really good question. So what we wanted to also mention, which is quite key for a lot of people, is that orgasm can be the actual physical orgasm, or it can be the sensation and the feeling of orgasm. So one person's orgasm to someone else is not necessarily the same. And the feeling of reaching sexual satisfaction can be counted as an orgasm for them. Yeah, so none of the participants had sacral sparing, so there was no pinprick or light touch sensation. So it is likely that any orgasm would have been due to reflexogenic rather than psychogenic. So yeah.
Great. Next question. What are the next steps for this research?
So I can only speak from my side. Dr. Darrow is the leader on this project, but it is still ongoing, the Eastern clinical trial. And so, as I said, this was just a case series of preliminary results. We are hoping to enhance the sample size. I know that they are looking to recruit additional participants starting next year. And so, yeah, hopefully for the female data, we will have a much larger sample to draw on. And at the moment, our team with Dr. Krasikov is looking at male sexual function from the same trial. So yeah, more to come.
Great. So you already hit two birds in one stone. You answered the second question as well, which was about the male subjects. So these were questions from Kevin and Ignacio. And I think those were the end of our questions. There's a comment from Blair Davis. Could you repeat the names of the questionnaires again, Claire, that you used for your study?
Sure. Sorry, I should have also given you a reference there, but female sexual function index. So the FSFI. And then there's the female sexual distress scale. So the FSFS, female sexual, yes.
And Ignacio is here.
Yes. Could I ask a question?
Sure. Please go ahead.
Please.
Specifically regarding the question that I asked about the male subjects, has a study like that been completed already, or is that something that the study is going to evolve into?
No, the Eastern trial is both males and females. We just chose to present female data first because it's a under prioritized area. But yeah, we are currently in the analysis phase of the males. And again, the trial's still ongoing and still recruiting, and it's both males and females. Yeah.
Okay, thank you.
Sure.
So if I can pick up on that thread a little bit, I'm guessing that the stimulator, well, we know from the clinical trials, is not targeting sexual function. It's targeting motor function or autonomic, and the E-stim parameters are tuned for either of those two outcomes. Do you think that the stimulator could be tuned for this use?
Yeah, no, I do. Of course, it's there's a lot of stimulation parameters that are still unknown with both epidural and transcutaneous, but there's a major big push at the moment towards pelvic function in general, and the overlapping neural networks between bladder, bowel, and sexual function means you could maybe not target sexual specifically, but you could target pelvic organs as a whole. And yeah, there's a lot of studies and publications coming out that you can benefit pelvic organ function. So yeah, I think if you were to fine tune stimulation parameters, you could get potentially even better results. At this point, we're not sure because it was a secondary analysis.
Yeah, so I would make a call that that's something we should pursue. Ignacio, are you back?
Yes, if I could ask a secondary question, which is about the stimulation sites. You said it's epidural?
Yes.
And is the lumbar or the coccyx, what is the area that is being stimulated, if I
Sure.
may?
So it's around T11, T12, L1 epidural implant, and that is the vertebral level. So if you're looking at a spinal cord level, then you're going to be hitting the lower portion of the sympathetic preganglionic neurons. So that's hitting the sympathetic aspect of sexual function, as well as the top portion of the sacral spinal cord. So S2, S4, which is responsible for the parasympathetic. So the location is trying to hit both aspects, both sympathetic and parasympathetic.
Thank you.
And since we have a little bit of time, if I can, Claire, you said there's no sacral sparing in any of the participants, and one was premenopausal. You displayed individual data on that plot with the bar graph. And I'm wondering about the lubrication for that person, because that's one of the areas where the stimulator was showing no effect. So do you have any thoughts on that?
Yeah, we were interested in that as well, that all the other functions went up and lubrication did not. And obviously lubrication is a key part of arousal and of easing the sexual process. So yeah, we proposed that postmenopausal might be a contributing factor. But again, that's only in one participant, and the other two didn't show much change either. So yeah, at this point, I'm not 100% sure, unfortunately, about why not. It might just be, yeah, not enough. The sample size is too small. Maybe we'll see a better trend. But hopefully we want to see that it's at least not getting worse, which is what we didn't see. So it's staying the same, might not be improving, but not getting worse. But yeah, definitely something we would want to look into in the additional analyses, see what is contributing to that and why.
Yeah, I mean, an acute measurement with a tuning of different electrical stimulation parameters could be some way to probe at that research-wise.
Yeah. Well, we've been working with Dr. Stacey Elliott, who is, I like to call her the sexpert. And yeah, she's phenomenal with all of this and has a lot of clinical experience. And so she's been guiding us through the processes, and we'll definitely look into it in our future analyses.
Claire, we have one more question in the chat box from Melina. And the question is, did the patients have orgasms previous to the injury? She has several SCI patients that did not even know what an orgasm was.
Mm-hmm. That is a really good point, and it's something we also thought of along the way. And we have mentioned it for the next recruitment cycle. It would be really important and interesting to have pre-injury sexual status. So yeah, getting a baseline before injury will let us know if there's any pre-existing conditions that have carried through, as well as things like intimacy with partners prior to. So yeah, it is a really important question to know what the patients were experiencing both before and at baseline. So yeah, it's a good point.
Great. Thanks, Claire. And one more question from Ignacio. What was the epidural stimulation on for 24 hours a day?
Yes, it was participants would, at the beginning, they kind of ramped up the hours. So in the first couple of weeks, a little bit less, but yeah, from there on, they had it on 24 hours a day, and they were different programs that they could select based on what activity they were doing. But most of them had active stimulation almost every day, all day. Yes.
Ignacio, that's a really unique part of this trial, and you should definitely go and look into the methods they use there. Very good. Really quick, Claire, the reference, mindfulness reference, was suggested or requested. Do you happen to remember the author?
It's Dr. Stacey Elliott. I just don't have I can't remember which one it is. Is Stacey here? She might know. Sorry, I'm not on my laptop.
It's all good.
I think it's Elliott, I know it's about 2017.
Let's see if I can find it.
Mindfulness, social mindfulness. Stacey Elliott.
No immediate hits.
And
this is good. You know you're in a talk about research when there's an emergency PubMed search being done in real time.
I'm happy to. Is it from? I can email it to you afterwards, and you can pass it along.
Absolutely, we'll do that.
Okay.
And Melly asked.
We have one more question from Melina. She's asking about the side effects, any negative outcomes of these trials.
None that were reported. So that's a really positive outcome because we know, especially with implantable devices, it's an invasive surgery, recovery time, infections, things like that could be a complication. But no, there were none reported in this trial.
Great. Thank you, Claire. It looks like David already shared a link. So Helen,
I found it.
you can look it up. So if there are no more questions, over to you, David.
Yes, so thank you so much for both of the presenters, all of the attendees for a nice participatory question session here. It was great. Had plenty of time for that, needed all of it. And so we sign off now. Asia's Early Career Webinar Series was founded, produced, and hosted by myself, David W. McMillan, Anne E. Palermo, and Raul Sachdeva of Asia's Early Career Webinar Series. And you have just viewed episode 6 on sexual and reproductive function following spinal cord injury. So thanks, everyone.
Thank you all.